Let's talk about breast carcinoma. Starting from the risk factors. The risk factors are early menarche, late menopause, means high estrogen states, increasing age, nulliparity, obesity, alcohol, family history, radiation exposure. These all are the risk factors. Coming to the pathology. Pathology includes P53 gene mutation, BRCA gene mutation. BRCA is BRCA1, which is chromosome 17q, BRCA2, which is chromosome 13q. Coming to the clinical presentation, there is a breast lump which is hard and painless. On nipple, you will find a discharge and it will be retracted as well. On skin, changes will be like ulceration, pudgy orange, dimpling, retraction, ulceration can be seen. Coming to how does this cancer spread? It spreads through local spread, lymphatic spread, or hematogenous. Local spread is, as the name suggests, through the infiltration of skin, resulting in ulceration. Lymphatic spread is along the axillary lymph nodes, which are the primary group of lymph nodes to be affected, and bloodstream is through the internal mammary artery. Now coming to the molecular classification of breast cancer. It's based on the gene expression profiling, ER, PR, HER2/neu, Ki67. So it is classified into luminal type A, luminal type B, basal type, HER2/neu enriched, claudin low, cytokeratin 5 negative. So your luminal A is ERPR positive and HER2/neu negative, and Ki67 is low. Luminal B is ERPR positive as well as HER2/neu positive. Basal type is triple negative, worst prognosis, most aggressive. HER2/neu is ERPR negative, HER2/neu positive, and claudin low is also triple negative, but it's cytokeratin 5 negative. That's the difference in it from the basal type. Coming to the TNM classification, this is classified into T0, T1, 2, 3, 4. 1 is tumor less than 2 centimeter, 2 is between 2 to 5, 5 is greater, T3 is greater than 5, T4 includes T4A, B, C, D. A is involving the chest wall, B is involving the skin, C is both skin and chest wall, D is inflammatory breast cancer. Coming to the lymph node is N1, N2, N3. N1 is mobile axillary lymph node, N2 is classified into N2A, N2B. N2A is fixed or matted, N2B is internal mammary lymph node involvement but no axillary, whereas N2A is axillary, N2B is IMA, N3A is infraclavicular, N3B is internal mammary and axillary, N3C is supraclavicular. And metastasis is very easy, M0 and M1. M0 no distant, M1 distant metastasis. Coming to the diagnosis is triple assessment, clinical examination, radiological examination, and histopathological examination. Clinical, we know the history and physical examination. Radiological, we know USG, mammography, MRI. Histopathological examination, we do the FNAC, trocar biopsy. Coming to the mammography, in mammography, you will see the microcalcification, whereas clinical examination, it's very easy. We follow the dial clock method, which is the best method to be followed. There are a few indications of MRI also, like in ladies with breast implant, multifocal diseases, we do go for MRI also. And in less than 40 years, we go for USG. In greater than 40 years, we go for X-ray. Now coming to the surgeries, which is the most important part. There are two types of surgeries: breast conservation surgery, mastectomy. In breast conservation, we do a lumpectomy followed by radiotherapy. Lumpectomy can be of two types: volume replacement, volume displacement. Volume replacement when it's the volume of the lump is greater than 15%, volume displacement when the volume is less than 15%. Now coming to some contradictions for the breast conservation surgery, like if it's a pregnant female, prior radiotherapy exposure has been done, it's multicentric multifocal tumor, or it's a locally advanced tumor or large tumor, we can't go for the breast conservation surgery. Now coming to the mastectomy, it's classified into simple radical and modified radical. In simple mastectomy, we remove the breast lump part, nipple areola complex, and the pectoralis fascia. Remember it. Whereas in the radical, we remove the breast lump, nipple areola complex, pectoralis fascia, plus the pectoralis major, minor, and also the lymph nodes of all three levels and the axillary lymph nodes. All these things are removed. Slight change was done in modified radical. It was sparing the pectoralis major. Rest all the things are same as the radical mastectomy. Now coming to the boundaries of the axillary dissection, it has four boundaries. The medial boundary is Holstead ligament, lateral boundary is thoracodorsal pedicle, superior boundary is axillary vein, inferior boundary is angular vein. Coming to the complications following the MRM, hemorrhage, injury to the nerves, like the intercostal brachial nerve can be damaged, which gives the sensory nerve supply to the axilla, long thoracic nerve, resulting in bending of scapula. Thoracodorsal nerve supplying the latissimus dorsi can also be damaged. Flap necrosis can occur. Seroma formation, lymphedema, recurrence, phantom breast syndrome. So these all are the complications starting from the hemorrhage, nerve injuries, flap necrosis, seroma formation, lymphedema, local recurrence, phantom breast syndrome. These are your complications following the mastectomy. Now coming to the chemotherapy. What are the indications? Indications are positive lymph nodes should be there. Triple negative breast cancer we give. We have also started now in HER2 positive tumors also. Tumor size should be greater than 1 centimeter and it should be a locally advanced tumor. We use the regimen of adriamycin plus cyclophosphamide 4 cycles or epirubicin plus cyclophosphamide followed by 4 cycles of paclitaxel. Coming to the next treatment modality, it's radiotherapy. Radiotherapy indications are post breast conservation surgery, tumor size is greater than 5 centimeter in locally advanced breast cancers, same as chemotherapy indications. Radiotherapy can be classified of two types: conventional and accelerated partial breast irradiation. In conventional, we give the whole breast the radiations, whereas in the accelerated, we give partial breast. Coming to the hormonal therapy, it's given in ERPR positive patients. If the female is premenopausal, we give SERM modulators, tamoxifen for 10 years, and if it's a postmenopausal female, we give aromatase inhibitors like letrozole for 10 years. So this was all about the treatment of breast cancer. Now specifically, we need to know, according to the TNM staging, which patient to operate, which to give chemotherapy, radiotherapy, where to give neoadjuvant therapy, where to do the same sentinel lymph node biopsy. These are your future questions. Thank you for watching.